Okay, let's unpack this. We've all seen those headlines, right? A new virus, a food recall, maybe a new screening recommendation.
Yeah, they come thick and fast sometimes.
But how do the experts, cut through all that noise? How do they actually figure out what's really going on with diseases or health trends?
That's the core question, isn't it? And it leads us right into epidemiology.
Right.
It's basically the science of figuring out the patterns, the causes, and the effects of health and disease conditions within populations.
And then using that knowledge to actually do something about it, to control health problems.
Exactly. It's detective work on a massive scale.
And for this deep dive, we're leaning on some really solid insights, essentially drawing from the foundational work laid out in a key textbook by Leon Gordis. It gives us the toolkit epidemiologists use.
It really does. It lays out the fundamental concepts and methods, the building blocks of the field.
So our mission here is to give you a shortcut, really. We're pulling out the key ideas, the main approaches, from tracking outbreaks to figuring out causes to seeing if health programs actually work.
And it's worth mentioning the people behind the ideas. Gordis himself was inspired by mentors like Dr. Milton Markowitz, who saw how epidemiology could evaluate health services, and Dr. Abraham Lilienfeld, who apparently had a real knack for communicating the excitement of discovery using these population methods.
It connects the science to real people doing crucial work. So let's jump into the roots. Epidemiology isn't just counting cases.
No, the definition is broader. It's the study of the distribution, like who gets sick, where, and when, and the determinants, the factors that influence that distribution. And crucially, applying this to control health problems.
You can see this thinking way back, can't you? Like with Ignaz Semmelweis in Vienna.
Oh, absolutely. The hand-washing story. It's a classic and pretty tragic in some ways.
Set the scene for us. Vienna, 1840s.
Right. You had two maternity clinics in the same hospital. The first clinic had horrifyingly high death rates from childbed fever, much higher than the second clinic.
And the big difference was who worked there.
Exactly. The first clinic was for training doctors and medical students, who often came straight from doing autopsies. The second clinic was run by midwives.
And Semmelweis put 2 and 2 together.
He suspected something was being carried from the cadavers on the hands of the staff. He called them cadaverous particles. His idea. Make everyone wash their hands with chlorinated lime between autopsies and examining patients.
Simple, but revolutionary for the time. And the results.
Dramatic. The death rate in the first clinic just plummeted, dropped right down to the level of the second clinic.
You'd think they'd have thrown him a parade.
You would, wouldn't you? But no. He faced huge resistance. Doctors didn't like the implication they were causing harm. Plus, the washing took time, and apparently Semmelweis himself wasn't the most diplomatic person.
So the evidence was there, but the change took years.
Many years. It's a powerful lesson in how, social factors and personalities can sometimes block scientific progress, even when the data seems clear.
Wow. And then there's John Snow in cholera in London, another foundational story.
Absolutely. A brilliant piece of shoe leather epidemiology, as they say. He didn't just accept the prevailing theories about bad air. He mapped the cases.
Right, the famous map showing cases clustered around the Broad Street pump.
Precisely. He used population data where people who died got their water to pinpoint the source. He provided strong evidence for waterborne transmission before the germ theory was even widely accepted.
These examples really show that core idea. Look at the patterns in the whole group, the population, to find answers.
It's the heart of the epidemiological approach.
Okay, so you've got these historical roots, these methods developing. If you're an epidemiologist today and you suspect something's going on, the next step is measurement, right? Quantifying it.
Yes, you need solid numbers. How often is this disease occurring? Who is it affecting? That starts with surveillance.
Like the systems that track flu cases each winter?
Exactly. That's often passive surveillance using existing data, like reports doctors are required to send in. It's relatively cheap and easy to set up.
But it has downsides.
Well, it can miss things. Underreporting is common. And the source notes that a few cases reported across a big area might not immediately signal a localized outbreak that needs attention. It might just look like background noise.
Like trying to spot a small fire from a plane just by seeing a few wisps of smoke here and there.
That's a good analogy. The source gives the example of tracking childhood thyroid cancer after the Chernobyl disaster. Surveillance showed an increase.
Okay.
But the immediate question was, is this a real increase in disease? Or is it because everyone was suddenly getting screened much more intensely, so we were just finding more cases that might have always been there?
That's a tricky distinction. Detection bias.
Right. Though in the Chernobyl case, the general consensus was that the increase was in fact real, but it highlights the caution needed when interpreting surveillance data.
So surveillance gives you the raw feed. How do you refine that into useful measures?
We use specific measures of morbidity or illness. Two key ones are incidence and prevalence.
Okay, break this down. Incidence.
Incidence is about new cases occurring over a specific period. It measures the rate at which people without the disease develop it. It's crucial for understanding risk.
Like the risk of catching the flu this winter.
Exactly. The source gives a calculation example. If a city called Atlantis, population 183,000, sees 26 new TB cases over 6 months, you can calculate the incidence rate. It's about the flow into the disease state.
Got it. New cases, flow, risk. What about prevalence?
Prevalence is different. It's a snapshot. It tells you the number of people who have the disease at a specific point in time, or over a short period. It's about the existing burden of disease in the population right now.
So incidence is the leaky faucet, prevalence is the amount of water already in the sink?
I like that. Yes, basically. They're related. Of course, higher incidence usually leads to higher prevalence, unless people recover or die quickly, but they measure different things.
Both sound important for different reasons.
They are. Another key concept, especially for understanding impact, is years of potential life loss, YPLL.
Okay, what's that measuring?
Instead of just counting deaths, YPLL gives more weight to deaths that happen at younger ages. It measures premature mortality.
So a death at 30 contributes more YPLL than a death at 80.
Precisely. It shifts the focus. The source points out that in the U.S., back in 2008, cancer was the second leading cause of death by simple count, but it caused the most YPLL.
Because it affects people across a wider age range, including middle age.
Right. And unintentional injuries, accidents were maybe 5th in overall deaths, but 3rd in YPLL because they're a leading cause of death for younger people. It really reframes public health priority.
That's a powerful metric, but what about the data itself? Like death certificates, are they reliable?
They vary. The source mentions they tend to be more accurate for causes like cancer than for some other diseases. And you have to be really careful when looking at trends over decades because the coding systems change.
The ICD codes.
Yeah, the International Classification of Diseases. When they revise the codes, like a big change around 1949, it can suddenly make it look like death rates for certain diseases jumped or fell when it was just a change in how things were classified on paper.
Ah, statistical artifact. Another trap for the unwary.
Definitely. And one more crucial thing for comparing populations or tracking trends, age adjustment.
Why is that so important?
Because a simple or crude death rate reflects two things: the actual risk of dying from diseases in that population and the age structure of the population.
Meaning an older population will just naturally have more deaths.
Exactly. Even if their age-specific risk is lower. The source uses a great example comparing U.S. and Mexico death rates. The crude U.S. rate was higher, but the U.S. has an older population.
So when you adjust for age,
The U.S. age-adjusted rate was actually lower than Mexico's. The adjustment removes the distortion caused by the different age structures, letting you compare the underlying mortality risk more fairly. It's like comparing apples to apples.
makes total sense. Okay, so we have the tools to measure. How do epidemiologists then start to understand the dynamics, how diseases spread, why patterns emerge?
A lot starts with basic descriptive epidemiology. Who gets the disease? Where do they live? When do they get sick? Person, place, and time.
Like the map of gonorrhea rates by state the source mentions.
Yes. Seeing those geographic clusters immediately makes you ask, are these differences real? Is the data good? If yes, then why? Is it something environmental? Differences in the people living there? Lifestyle factors?
It generates hypotheses.
Precisely. Another key dynamic is the spectrum of disease severity. Many infections don't cause obvious illness in everyone they infect.
Like polio, which you mentioned earlier.
Right. The source points out that most polio infections back in the day were subclinical or inapparent. People didn't feel sick, but they can still spread the virus. Understanding that hidden part of the iceberg is critical for controlling transmission.
You can't just count the people who end up in iron lungs.
Exactly. Tuberculosis is similar to many inapparent infections. Rabies, on the other hand, is the extreme opposite. Pretty much no inapparent cases, and nearly always fatal if untreated. The spectrum varies hugely.
What about specific outbreak patterns? Like on a cruise ship?
Yes, the classic common vehicle outbreak. If everyone's exposed to the same source around the same time contaminated food at a banquet, you see a characteristic epidemic curve.
Which looks like?
A sharp rise in cases, a peak, and then a fairly rapid decline as the source is removed or people are no longer exposed. The neurovirus outbreaks that the CDC tracks on ships often follow this pattern.
And that pattern helps confirm it was a single source and also tells you about the incubation period.
Yes, the time between exposure and getting sick. You can estimate it from the timing of the outbreak peak relative to the exposure.
And then there's the concept of herd immunity.
Crucial for vaccination programs. It's the idea that if enough people in a population are immune, they form a protective barrier that stops the disease from spreading easily, which protects vulnerable, non-immune individuals too.
But the percentage needed varies.
Oh yes, highly contagious diseases like measles require a very high threshold. The source says around 94% immunity needed in the population to really stop transmission effectively.
That's a really high bar. The source also showed the rapid spread of West Nile virus across the U.S.
Yeah, a striking example of how a new infectious agent can establish itself and spread geographically, and also showing clear seasonal patterns linked to mosquito vectors peaking in late summer.
This all leads into thinking about, well, future threats, doesn't it? Like pandemics.
Absolutely. The source touches on concerns about viruses like H5N1 avian flu potentially mutating to spread easily between people. And it mentions the quite controversial research where scientists actually engineered more transmissible strains in the lab.
That raised some serious ethical debates.
It certainly did. Big questions about weighing the potential benefits of understanding transmission against the risks of accidentally or intentionally releasing a dangerous pathogen, a very tricky area.
Definitely. Okay, so we measure disease, we track its dynamics. But what about identifying who has a disease, especially through screening? That brings us to diagnostic tests.
Right. And evaluating how good a test is involves some specific concepts. Let's assume a simple test, positive or negative. Two key measures are sensitivity and specificity.
Sensitivity is catching the people who actually have the disease.
Correct. It's the proportion of people with the disease who test positive. High sensitivity means fewer false negatives.
And specificity is correctly identifying those who don't have it.
Yes, the proportion of people without the disease who test negative. High specificity means fewer false positives.
Okay, sensitivity and specificity describe the test itself. But what a patient wants to know is, I got a positive test. What are the chances I actually have the disease?
Exactly. And that's measured by the positive predictive value, or PPV. It's the probability that someone testing positive truly has the disease. And here's the crucial part. PPV is heavily influenced by the prevalence of the disease in the population being tested.
Meaning how common or rare the disease is.
Yes. Even a test with pretty good sensitivity and specificity can have a surprisingly low PPV if you use it to screen a general population where the disease is rare.
Why is that?
Because in a low prevalence setting, most people don't have the disease. So even a low false positive rate, high specificity, applied to that large number of healthy people will generate a substantial number of false positive results. These can easily outnumber the true positives from the few people who actually have the disease.
So a positive screening test, especially for a rare condition, might be more likely to be a false alarm than real.
It can be, yes. The source has examples showing this clearly. It really underscores why positive screening tests always need follow-up confirmation with more definitive tests. PPV tells you how much to believe that positive result in your specific situation.
That's a really important takeaway for anyone undergoing screening. What about test reliability?
Also important, does the test give consistent results? If two different labs run the same sample, do they get the same answer? Or if the same pathologist reads a slide twice? The source mentions measures like the kappa statistic to quantify agreement beyond what you'd expect by chance.
Okay, so tests help identify disease. But once someone is diagnosed, what can epidemiology tell us about their likely future? Prognosis.
Yeah, understanding the natural history and prognosis of a disease is another key area. A common measure here is survival time.
And you usually start measuring survival from the time of diagnosis.
Often, yes, for consistency. But it has limitations because diagnosis doesn't always happen at the same point in the disease course for everyone. Ideally, you'd measure from biological onset, but that's usually impossible to know.
We hear a lot about 5-year survival rates.
We do. It's a common benchmark, but it can be misleading on its own. The source points out that 2 treatments could lead to the same 5-year survival rate, but one might involve many deaths occurring early on, while the other has deaths spread out more evenly or occurring later. The single 5-year number hides that difference.
So you really need to see the whole picture over time.
Exactly. That's why survival curves are so useful. They graph the proportion of people surviving over time. Methods like Kaplan-Meier analysis let you visualize this and statistically compare curves, say, between a treated group and an untreated group.
What's relative survival?
That's a way to adjust for background mortality. It compares the observed survival in the group with the disease to the survival you'd expect in a similar group of people without the disease from the general population, matched on age, sex, etc.
So it tries to isolate the excess mortality caused specifically by the disease itself.
Yes. It accounts for the fact that people would be dying from other causes anyway. Relative survival will always be higher than the simple observed survival rate.
Makes sense. Now, the source mentions something called the Will Rogers phenomenon, or stage migration. Sounds intriguing.
It is. It's a type of bias that can happen when new, better diagnostic tests are introduced.
How does better diagnosis create bias?
You can make survival statistics look better artifactually without any actual improvement in treatment or the disease's natural course.
Yeah.
It happens in a couple of ways. One, the better test might simply detect the disease earlier than before, so people diagnosed earlier appear to survive longer from diagnosis, even if they die at the same actual time. That's lead time bias, which we'll come back to with screening.
Okay.
But stage migration specifically refers to how better tests can reclassify patients. For instance, a new scan might detect small metastases that older scans missed, moving a patient from, say, stage 2 cancer to stage 4.
Right.
Now, these newly reclassified stage 4 patients are generally healthier, they have less advanced disease, than the original stage 4 patients diagnosed with older methods. So when you average them in, the overall survival rate for stage 4 appears to improve. Similarly, the stage 2 group now has its worst cases removed, reclassified to stage 4, so its survival also appears to improve.
Ah, so you haven't cured anyone, you've just shuffled the labels around based on better detection.
Exactly. Will Rogers apparently joked about the Okies moving from Oklahoma to California during the Dust Bowl, raising the average intelligence in both states. It's the same statistical principle. Better detection resorts patients, making outcomes look better in multiple groups without any real change in prognosis.
That's a really subtle but powerful bias to be aware of when looking at cancer survival trends over time.
Hugely important.
Okay, let's shift gears. We've talked about measuring, tracking, diagnosing, predicting, but a huge part of epidemiology is figuring out what works, evaluating interventions.
Absolutely. And for evaluating treatments or preventive measures, the randomized controlled trial, the RCT, is really held up as the gold standard design.
Why is it the gold standard?
Because randomization, randomly assigning participants to either get the new intervention or be in a control group, getting standard care or placebo, is the best tool we have to make the groups comparable at the start of the study.
Comparable in ways you can measure, like age, but also in ways you can't measure.
Exactly. Unknown factors, genetic predispositions, lifestyle things. Randomization tends to distribute all those factors evenly between the groups, by chance. If the groups start out the same, on average, then any difference in outcome you see at the end is much more likely to be due to the intervention itself, not some pre-existing difference. It minimizes bias and confounding.
The source mentions James Lind and scurvy back in the 1700s as an early example.
Yeah, one of the very first documented controlled trials. He took sailors with scurvy, made sure they had similar conditions in diet, and then gave small groups different potential remedies: cider, vinegar, citrus fruits. A systematic comparison.
And the citrus group got better.
Famously, yes. Modern RCTs formalize this with that key step: random assignment.
Why isn't just alternating, you get treatment A, next person gets B, etc., good enough?
Because alternation is predictable. If the person enrolling patients knows who's next in line for which treatment, they might consciously or unconsciously steer certain types of patients towards one group or another, introducing bias. True randomization uses unpredictable methods, like random number tables or computer generation.
Unpredictability is key, and blinding.
Also crucial for minimizing bias. In a double-blind study, neither the participant nor the researcher assessing the outcome knows who received the real treatment and who received the placebo or standard care.
Why is that important?
It prevents expectations from influencing results. Patients who know they got the new drug might feel better or report symptoms differently, subject bias. Researchers who know might assess outcomes differently, maybe looking harder for improvement in the treatment group, observer bias. Blinding takes those expectations out of the equation.
Okay, so randomization makes the groups comparable. Blinding prevents biased assessment. What about analyzing the results? The source mentions intention to treat.
Yes, this is a really important principle for analyzing RCT data. It means you analyze participants based on the group they were initially randomized to, no matter what happened later.
Even if they stop taking the study drug or switch to the other group's treatment.
Even then, you analyze them as if they stayed in their original group.
That seems odd. Why not just analyze the people who actually followed the plan?
Because the moment people start dropping out or switching treatments, the original randomization is broken. The groups are no longer necessarily comparable. Analyzing only the perfect participants, per protocol analysis, can reintroduce bias. Intention to treat preserves the benefit of randomization. It compares the strategy of assigning someone to treatment A versus treatment B, reflecting what happens in the real world where adherence isn't perfect. It gives a more pragmatic estimate of effectiveness.
Okay, that makes sense. Analyze based on original assignment to keep things fair. The source also mentions factorial designs.
Yeah, a clever way to test 2 or more interventions in the same study. The Physician's Health Study is a famous example. It had a 2x2 factorial design testing both low-dose aspirin and beta-carotene for preventing cardiovascular disease and cancer.
So participants could get aspirin plus placebo, beta-carotene plus placebo, both, or neither. Efficient.
Very. And as you noted, the aspirin arm was stopped early because the benefit in reducing heart attack risk was so clear and ethically compelling. That also highlights the need for having enough participants sample size.
Right, you need enough people to be confident in the results.
Exactly. Statistical power. You need to calculate beforehand how many participants you'll likely need to detect a clinically meaningful difference, if one exists, without the result being just due to chance. Too small a study might miss a real effect, a false negative.
And if you can't get enough people,
The source suggests options. Maybe collaborate with other centers to pool participants, extend the recruitment period, or sometimes conclude that the study just isn't feasible with the available resources.
RCTs sound powerful, but the source gives examples where they really challenged conventional wisdom, like the tamoxifen trial.
Yes, observational studies suggested tamoxifen might prevent breast cancer in women at high risk. The RCT confirmed this benefit, but also detected an increased risk of endometrial cancer and blood clots. It showed the crucial need to rigorously assess both benefits and harms, which RCTs are well suited to do.
And the arthroscopic knee surgery study is just stunning.
It really is. Knee arthroscopy for osteoarthritis was incredibly common, but early studies lacked good controls. Mosley and colleagues did an RCT with a sham surgery control group.
Meaning some patients got incisions, heard the sounds, but didn't actually have the surgical procedure done inside the knee.
Precisely. And the results were clear. Over 2 years, patients who got the real arthroscopic procedures, debridement or lavage, reported no more pain relief or functional improvement than those who got the placebo surgery.
Wow. That basically showed the perceived benefit was likely due to the placebo effect or natural history, not the surgery itself.
It had a huge impact and underscored the critical need for rigorous placebo controls, even for surgical interventions, which are much harder to study than pills.
It really highlights why you need these careful trials before adopting widespread practices.
Absolutely. The source also notes similar stories with psychosocial interventions for cancer. Early promising hints from less rigorous studies often weren't confirmed in later large RCTs. You need the strong design.
Even chicken soup gets a mention.
Ha, yes. A lighthearted point from the source about how difficult it is to scientifically evaluate something so ingrained in culture and anecdote, despite generations swearing by it.
Okay, so RCTs are the go-to for testing interventions. But what about studying the causes of disease, especially when you can't ethically randomize people to something harmful, like smoking or pollution?
Right. For etiology, or cause finding, we rely heavily on observational study designs. No random assignment here, we observe what people are doing or exposed to anyway. The 2 main workhorses are cohort studies and case control studies.
Let's start with cohort studies. How do they work?
In a cohort study, you identify groups of people based on their exposure status, say, a group of smokers and a comparable group of non-smokers who are initially free of the disease you're interested in, like lung cancer.
Okay, exposed and unexposed groups. Then what?
Then you follow them forward over time, sometimes for many years, to see who develops the disease in each group. You compare the incidence rate, new cases, in the exposed group to the incidence rate in the unexposed group.
So you're starting with the potential cause, exposure, and looking forward to see the effect disease.
Exactly. The Framingham Heart Study is a famous example of a cohort study looking at risk factors for cardiovascular disease. The source gives a hypothetical example showing higher heart disease incidence in smokers.
What are the pros and cons?
Pros. You can establish that the exposure came before the disease, temporality. You can study multiple outcomes from a single exposure, and you can calculate incidence rates directly. Cons. They can be very time-consuming and expensive, especially for long follow-up periods. They're not efficient for rare diseases because you need huge numbers of people to get enough cases, and people can drop out over time, lost to follow-up, which can bias results.
Okay, so what's the alternative? Case control studies.
Yes. These work in the opposite direction.
Yeah.
You start by identifying people who already have the disease, the cases, and a comparable group of people who don't have the disease, the controls.
So start with the effect, disease.
And then look backward in time to determine and compare their past exposure to potential risk factors. You ask, what proportion of the cases were exposed compared to the proportion of controls who were exposed?
Like the early smoking and lung cancer studies.
Exactly. Dolan-Hill's landmark study was a case control design. They found far more heavy smokers among the lung cancer cases than among their control group, providing strong evidence for an association.
Advantages of this design.
Much quicker and less expensive than cohort studies. You need fewer subjects. They are particularly good for studying rare diseases because you start by finding the cases, however few there are, and you can investigate multiple potential exposures at once for a single disease.
Sounds efficient. What are the main challenges?
The biggest challenges often revolve around potential biases. Selecting an appropriate control group is critical and can be very tricky. The controls need to be representative of the population from which the cases arose.
Like the example you gave earlier, avoiding controls whose own conditions are linked to the exposure you're studying.
Precisely. Using hospital controls can be convenient, but you have to be careful they aren't hospitalized for exposure-related conditions. Another major potential bias is recall bias.
People remembering past exposures differently.
Yes. Cases, perhaps searching for a reason for their illness, might recall past exposures more thoroughly or differently than healthy controls. This is especially a concern for exposures that happened long ago or are hard to remember accurately, like diet or intermittent medication use.
So cohort studies go forward, less prone to recall bias, but slow and costly. Case control studies go backward, faster and cheaper, good for rare diseases, but need careful control selection and worry about recall bias.
That's a good summary. They complement each other. The source also mentions variations like nested case control studies, where you conduct a case control study within an existing cohort, leveraging previously collected data.
Okay, so whether it's a cohort or case control study, you might find an association that exposure seems linked to the disease, but that's not the end of the story, is it? Association isn't causation.
Absolutely not. Finding an association is just the first step. The crucial and often difficult second step is trying to infer whether that association is likely causal.
How do you quantify the association itself?
We use measures like relative risk, RR. In cohort studies, the ratio of incidence in the exposed to incidence in the unexposed. An RR of 2 means the exposed group has twice the risk, or the odds ratio, OR, in case control studies, which compares the odds of exposure in cases versus controls. For rare diseases, the OR provides a good estimate of the RR.
So R and OR tell you the strength of the link.
They quantify the magnitude, yes, but a strong association could still be due to other factors. Before inferring causality, you absolutely must consider bias and confounding.
We've talked about bias, systematic errors, and how the study was designed or conducted. What about confounding again?
Confounding is when a third factor is mixed up with the exposure and the disease, distorting the apparent relationship. The factor has to be associated with both the exposure and independently affect the risk of the disease.
The coffee smoking pancreatic cancer example.
Classic example. Smoking is linked to coffee drinking, exposure, and is also an independent risk factor for pancreatic cancer disease. If you don't account for smoking, it might look like coffee causes the cancer when really smoking is the confounder driving the association.
How do you deal with confounding?
In the analysis phase, you can use methods like stratification, analyzing the association separately within different levels of the confounding factor. For example, looking at the coffee cancer link separately for smokers and non-smokers. Or statistical modeling can adjust for potential confounders. In the design phase, you might use matching in a case control study, though that has its own implications.
So you find an association. Check for bias, check for confounding. What else?
You also need to consider interaction or effect modification. This is when the effect of one exposure is different depending on the presence of another factor. It's not just confounding. The two factors work together, often synergistically.
Like the asbestos and smoking example for lung cancer risk.
Exactly. The risk for someone exposed to both asbestos and smoking is far, far greater than just adding their individual risks together. They multiply each other's effects dramatically. The course also mentions alcohol and smoking for oral cancer, and the factor V Leiden gene mutation interacting with oral contraceptive use for thrombosis risk. It's about combined effects being more than the sum of their parts.
Okay, so association established, bias and confounding considered, interaction explored. Then how do you make the leap to saying, yes, this exposure likely causes this disease?
That's where you apply judgment, guided by frameworks like the Bradford Hill guidelines, or viewpoints, as he preferred to call them. These aren't a rigid checklist, but criteria to help weigh the total evidence. Hill's question was essentially, is there any other explanation that fits the facts as well or better than cause and effect?
What are the key criteria in this framework?
Well, first and foremost, temporality. The cause must precede the effect. Exposure has to come before disease onset. Seems obvious, but essential. Then, strength of association. A strong RR or OR makes chance less likely. Those strong associations can still be confounded. Dose-response relationship. Does increasing exposure lead to increasing risk? Like smoking more cigarettes per day leading to higher lung cancer risk. That's powerful evidence.
What else?
Consistency replication. Has the association been observed by different researchers in different populations using different methods? Biologic plausibility. Does the association make sense based on current biological knowledge? Though Hill wisely noted that biological understanding often follows epidemiological observation, like with rubella and birth defects.
So epidemiology can point the way even before the lab catches up.
Absolutely. Other criteria include cessation of exposure. Does the risk decline if the exposure is removed, like lung cancer risk dropping after quitting smoking? Consistency with other knowledge. Does it fit with experimental evidence or other relevant data? And consideration of alternate explanations. Have bias and confounding been thoroughly ruled out?
What about specificity? One cause, one effect.
Hill included it, but the source rightly points out it's the weakest guideline and perhaps should be dropped. Many exposures cause multiple diseases, smoking being the prime example, and many diseases have multiple causes. Relying on specificity is often misleading.
So it's about the whole pattern of evidence, not just ticking boxes.
Exactly, the total picture. The source highlights the H. pylori story as a modern example, where accumulating evidence from different types of studies, fitting many of Hill's criteria, led to the conclusion that this bacterium causes peptic ulcers, a Nobel Prize-winning discovery.
That's a great illustration. Now, how does all this epidemiological knowledge get applied in the real world, for instance, in evaluating health services or informing policy?
Big applications there. Evaluating health services, figuring out if programs or ways of organizing care actually improve outcomes, is crucial but complex.
Why complex?
Because often you can't randomize. If you just compare people who choose to use a service, like attending a wellness program, with those who don't, the groups might be very different to begin with. The users might be more health conscious overall. That's self-selection bias.
Like the prenatal care example you mentioned, lower death rates in those getting care, but maybe they were just healthier, more motivated people anyway.
Exactly. It's hard to disentangle the effect of the service from the characteristics of the people using it without randomization. That's why, when feasible, RCTs are the strongest way to evaluate health service interventions too. The source cites a trial randomizing stroke patients to different care models, specialized unit versus general ward versus home care, which clearly showed benefits for the specialized unit.
So RCTs aren't just for drugs. What about screening programs? That's another huge area of policy and practice.
Yes, evaluating screening testing, apparently healthy people to find disease early, is critically important, but also fraught with potential biases if not done carefully.
What biases are specific to evaluating screening?
3 big ones can make screening look good even if it isn't actually extending life. First, lead time bias. Screening detects disease earlier in its natural history than waiting for symptoms. This earlier diagnosis automatically increases the measured survival time from diagnosis, even if the time of death doesn't change.
It just gives you a longer time knowing you have the disease. The clock starts earlier.
Right. Second, length-biased sampling. Screening tests are inherently more likely to detect slow-growing, less aggressive forms of a disease, simply because those forms exist in the detectable preclinical phase for a longer time. Fast-growing aggressive cases might develop and cause symptoms between screening rounds. So, screen-detected cases tend to have a better prognosis anyway, just because they're the slower-growing ones.
You're preferentially catching the turtles, not the hares.
Exactly. And third, overdiagnosis bias. Screening can detect abnormalities that meet the pathological definition of disease, like some early-stage cancers, but which would never have progressed to cause symptoms or death during the person's lifetime. Treating these overdiagnosed cases adds to the number of cancers found and treated, but provides no actual benefit, just potential harm from treatment.
Wow. Lead time, length bias, overdiagnosis. These make it really hard to know if screening is truly beneficial just by looking at survival rates of screened versus unscreened people in observational data.
Extremely hard. That's why large, well-conducted randomized trials comparing mortality outcomes in a group invited to screening versus a control group not invited are considered the most reliable way to evaluate screening effectiveness. They automatically account for these biases.
Like the HIP study for mammography.
Yes, a landmark RCT. And the ongoing debates about mammography for women in their 40s highlight the challenges when the evidence from trials is less clear-cut for specific subgroups.
The source also notes the irony with cervical cancer screening.
Yeah, it's widely accepted as effective based on observational data showing declines in mortality after screening was introduced. But it was never rigorously evaluated in a large RCT initially, which leaves more uncertainty about its true impact compared to, say, how we evaluate new drugs today.
It's a different standard of evidence. Fascinating. Finally, the source touches on broader dimensions: genetics, policy, ethics.
Right. Epidemiology plays a key role in understanding gene-environment interactions. Twin studies, comparing identical versus fraternal twins, help tease out genetic contributions. Familial aggregation studies look at clustering in families.
And we see examples like factor V Leiden interacting with birth control pills.
A perfect example of how a specific gene variant can dramatically alter the risk from an environmental exposure. This whole area of genetic epidemiology is exploding, but also raises complex ethical issues around testing, risk communication, and potential discrimination.
And the connection to policy is clear throughout.
Absolutely. Epidemiologic evidence directly informs clinical guidelines, public health regulations, prevention strategies. The example of hormone replacement therapy, HRT, is stark observational studies suggested benefits, but large RCTs later showed increased risks for some outcomes, leading to major policy shifts.
It shows the importance of relying on the strongest evidence, even if it contradicts earlier beliefs.
Definitely. The source also mentions meta-analysis, statistically combining results from multiple studies as a tool used in policymaking, while cautioning about its potential pitfalls like publication bias or combining apples and oranges if the studies are too different. Uncertainty is always part of the picture.
And this all ties into ethical responsibilities for researchers.
Yes. Informed consent, protecting participant confidentiality and privacy, which is increasingly complex, reporting findings responsibly without causing undue alarm, disclosing conflicts of interest. These are all critical professional obligations.
The source also mentions the sensitive issue of using race and ethnicity in research.
It does, acknowledging the difficulties in definition and the risks of misuse, but also noting its use in identifying health disparities that need addressing. It calls for careful interpretation and avoiding simplistic biological conclusions based on social categories.
It really sounds like epidemiology is about much more than just numbers. It requires critical thinking, collaboration, and ethical awareness.
That's the final message from the source: connectedness. Epidemiologists need to work across disciplines and engage with the complexities of health and society to be truly effective, learning perhaps from the communication failures faced by pioneers like Semmelweis.
So let's try to wrap this up. We've journeyed from the early detective work of Snow and Semmelweis through the essential tools of measurement, incidence, prevalence, YPLL, age adjustment. We've looked at tracking disease dynamics and the tricky biases in evaluating diagnostic tests and screening programs like lead time and length bias.
We dove into the strengths and weaknesses of randomized trials as the gold standard for interventions, versus observational designs like cohort and case control studies used to investigate causes. We unpacked the critical steps of assessing association, dealing with bias and confounding, and applying careful judgment like the Bradford-Hill criteria to infer causation.
And we've seen how all this applies to evaluating health services, informing policy, understanding gene-environment interactions, and the ethical considerations inherent in studying human health at the population level. It really provides the framework for making sense of health news and recommendations.
It absolutely does. These are the fundamental tools experts use to figure out what influences your health, my health, and the health of entire communities.
Okay, so building on all that, here's a final thought for you, our listener, to mull over. Given everything we've discussed today, the different study designs, the potential for bias, the careful steps needed to infer causation when you encounter a new health claim or study result in the media, what's the single most important question you should ask yourself first to begin evaluating it critically?